Dear colleagues, let us start the second part of our session. This is continuation of the previous session. That is why, if any of you have questions related to the first part of our session, you can ask now if you have some unanswered question. Alexander Kryuchko will continue his speech, and I believe this will be a logical continuation of the report. Let's listen to his speech. Dear friends, actually I would be pleased to provide a couple of formula and to see how we do practical applications of this formula. Another page from Mathematics and Physics for Humanitarian Specialists. At this slide, you see the X-ray of patients who are balanced and not balanced. And we see some patients who feel best, X-rayed, and to the right we see that he is bent forwards. And it's not only this, but he is also trying to somehow compensate this by bending his joints. And he cannot feel how bad he feels because he cannot walk, actually. And often these kind of patients require surgery, and as long as the theme of this report was monosegmentary correction of revision surgery, I would like to this is mostly a report for specialists, but I would like to make some specifying remarks. Number one, the calculations that I have provided in my first report, this is daily practice, and all patients who require decompressive stabilizing surgery will make X-ray research full height. And just to show the importance of these calculations, I would like to use a couple of examples. One of the examples is shown at the slide. The patient has gone through a surgery that was successful, wonderful construction position. This is a cylinder shape, but at the time when this surgery was done, it was most available. This is 2000. And what we would like to attract your attention to, this important angle L4S1 in post-surgical period equals 18 degrees. And according to calculations, it should be 43. It looks like only in these figures we made mistakes, and all the rest is done very well. The compression is done, and how to move on. And further on, this patient, if you look carefully, there is instability of the higher segment and a kind of spondylolisthesis. What is a syndrome of an adjacent level? We operate on this patient. We see the revision, quite another good surgery, but the angle remains the same. The angle between L1S4 is 18 degrees and general lordosis is 50 when it should be 60. Not a big loss. With the time, this lordosis got decreased because slowly frontal parts of discs lose their height, and as a result we have such a situation. After the second surgery, these patients come to us again, and we again see spondylolisthesis of the same level. Of course it requires surgery, but when we are going to finish this surgery, because the angle still remains the same, 18 degrees S1L4, how we can get out of this circle? And by the way, the level is below how much intact it is, because it goes to kyphosis slowly. And if we look at this shot, we see that it's not the disease of adjacent level, but actually it is a transition to kyphosis of above and the lower level. What can we do with this patient? Was there any mistake when we performed the first surgery, removing lordosis without doing these kind of calculations. I would like to show you once again, at this slide you see how with the time we lose the height of the discs and which deformation it results in. And we see it with this patient that he's bent forwards. Actually, it's a young woman, around 50 years old, but you see the deformation of the spinal part. She cannot carry herself in a good way, so that her muscles would function so that their efficiency would be highest. When we perform this kind of surgery, preserving backbone lordosis for this patient, we reached quite a good level of lordosis, and we observed it for 6 years. There were no special problems. And or this patient who came to us also with distortion of sagittal balance, and he addressed related about intensive pains. We see that at the same level he has kyphosis, and this kyphosis, which took place at the same level, L4, L5, results in considerable disbalance. And there is a question whether it will be enough for this patient to operate only one level, and what should be the technology of operation and which result we should reach. Having made the calculations, we understand that we should reach specific angle, lordotic angle at the level 4-5. And performing this surgery, we see that there is total normalization of all the parameters of spinal sagittal balance with a regression of pain syndrome. Thus, we can come to a conclusion that the example I have shown you initially contained a mistake in surgery planning, and insufficient angle of lordosis at L4, L5 steadily comes to the need to make a surgery on this patient again and again. And thus, even a surgery at one backbone, lower back segment, its fixation should be always be taken into consideration. As surgeons, we always should consider these kind of parameters of sagittal balance. Or this kind of situation, is it going to be enough to perform surgery? I can tell you that maybe we could make only foraminectomy in order to change the quality of life of this patient. Just a lyrical digression. At scoliosis with adults, normally we use classification Schwab, which actually shows this deformation in figures, of sagittal balance, or to be exact, disbalance. To what extent this patient is disbalanced, and all this classification offers to a surgeon to correct the pathology, bringing it as close to the norm as possible. And that is why, in this case, it's not applicable to use some isolated decompression, because patient is worried with considerable shortening of walking distance. During the first time we performed lateral axis, we corrected axial deformation with this patient, then frontal axis to correct angular relations. We see that the angles are normal, and then, as you can see, this patient got straight, and the walking distance became unlimited. What we had before the surgery and after. And this is the result, so-called indirect decompression. We can see that there is a change of relations in spinal segment, and the amount of spinal column channel decreased, and it also creates the recession of clinical symptoms. That's all I wanted to say. Thank you. Thank you very much. We will continue discussion on sagittal balance. In this or that way, it is going to be specified in all the reports. But do you have any questions right now? And maybe somebody have questions from the first part. of the session. Comments to the speakers? No? Maybe Sergei Gennadievich, during his report, will speak about some issues, because he cannot avoid questions, as the theme is degenerative deformations. We'll listen to what problems Sergei Gennadievich faces and how he solves this problem. And I would like to introduce him. You see one of the most well-known Russian vertebrologists, surgeons, who somehow, with some miracle, combines the work of daily practicing surgeon with the position of head of largest and most well-known institution of traumatology and orthopedics in Nizhny Novgorod. How he manages to do this, well, he will tell you. Will you tell us someday? Well, maybe some other time. Thank you very much. Thank you for this introduction. I think it was too much, but thank you very much for coming here in day off and listen to our complicated stories about biomechanics of the spinal column, about such unclear thing as sagittal balance. But unfortunately, probably we need to state that we cannot, no matter what Dmitry Nikolaevich is telling us, he is trying to bring us to his army, which intends directly against sagittal balance. So maybe I'm exaggerating, but still I prefer to stay in the army of Alexander Vladimirovich with Novosibirsk. That is why I'm sitting here at the side, at the right part. Well, truly, degenerative deformations are called degenerative because they are developed, and unfortunately they occur not right at once. And everything starts with a commonplace process which is called osteochondrosis, and unfortunately everyone sitting here without an exception are either suffering or are going to suffer from this disease, but thanks God not everyone is going to face degenerative deformations. If we watch this slide, even non-specialist, even not a medical person understands that there is some deformation on the right and on the left. There are two patients, and these deformations are similar, but on the other hand, they are different, and the complaints of these patients are different as well. Just briefly, how often these deformations take place? People above 40, up to 10%. So out of 10 people, one will certainly have this kind of deformation. Add that in 30% of cases, this deformation do not have any symptoms, and the person luckily lives his life not knowing sometimes if he doesn't make MRT or CT or X-ray and good. But the remaining part, that is 70% of those who have complaints, they come to doctors, and then there is a process of treatment. Conservative treatment in 15% is getting complications, and in surgery it's even worse, up to 60% of complications. Alexander Vladimirovich already mentioned that this such an organization, which is almost 70 years old, people from SRS make a very serious and constant researches. So this table describes different options for interferences at degenerative deformations. Some limitations for this. Looks like everything is described, and the doctor only has to learn English, translate into Russian, put this table in his room, and clearly follow the recommendations. Unfortunately, the same association makes the following conclusion, that actually the recommendations for the surgery is not absolute, and they should be considered only with the consideration of specific factors, that is individual approach. There are the only one correct way of treatment this deformation, and there are no such kind of recommendations about how we can use operative strategy, and it can be done only in case of well-informed cooperation between the doctor and the patient. What is the idea? Well, I try to speak about it in my clinics. When we see these patients with us, first of all, we explain where this deformation comes from, or how it is going to develop, and how you can live with this deformation. It is said by a surgeon who's actually who should be for surgery, and I have always insisted that before a patient says yes to the surgeon, and his relatives will always confirm that the patient should go through the stage of conservative treatment, regardless of the kind of deformation. Just as an example, typical deformation, reminding of the one which Alexander Vladimirovich has just shown, 45 degrees, quite well expressed, but there is no neurological symptomation. The walking distance is reducing, and back pain complaints. Conservative treatment was inefficient. At MRI, we see the standard picture of secondary stenosis, and thus pains are explainable. We make functional shots. This is standard examination for this patient, so I understand that there is no instability, but there is kind of flexibility which is there. And here we come to decision-taking phase. In this situation, what was said by Alexander Vladimirovich, this patient has considerable disorders from the point of view of sagittal balance. Then lower back lordosis is decreased, and doctors decides to make quite considerable traumatic interference, multi-level mobilization, osteotomy, and this is many-hour surgery with large blood loss, and the patient heroically agrees, and we see the shots after the surgery. Looks like it is a wonderful result. However, what happens next? Next we see that after some time the patient anyway, so our patients, if something is wrong, our patients become our relatives, so the patient complains on the back pains again. So some of the indications are normal, and another indication, I will not call it in English, just not to mislead you. So it goes outside the limits, and it goes outside the limits considerably. So there is a question, what to do with this patient? Maybe we should send him to Mark Yakovlevich, who is going to have a speech, and he will train low-invasive methodology, pain management, and we will stop thinking about secondary surgery. Or a doctor will have a question, no, we have to revise this construction. We have to further on interfere, maybe go downwards or do additional osteotomy, which, if you just imagine that this is a secondary large operation. Another case, a patient of 46, a young age, in 2016 that took place, back pains, neurogen limbing within 1 and 5 years, instability, dynamic stenosis. So we assess the parameter of sagittal balance. They are outside the normal frames, and we take similar decision. We make 3-level spondylosis. We're happy with the partial recovery of some parameters. Yes, the patient leaves us with a good result, but after 2 years, again, pains occur. We do not wait until everything gets worse. We make functional pictures and see hyperflexibility in this segment, and also after almost a year, we see that the patient has a considerable repeated disorder of sagittal balance, and here the surgeon cannot but send a patient to conservative treatment, and he has to offer only large-scale surgery. So we make this prolonged fixation, and then there is another complication, another revision. We fix the hip joints, and we reduce our digressions are almost over. Soon we'll face the wall, as the surgeon says. We have only upper upper cervical vertebral and neck remaining. That's all. What can we do then? After 3 years of the second revision, and the patient is still complaining, and almost normal parameters of sagittal balance. Everybody is surprised, even X-ray specialists who often disagree with us. And then we take a non-standard decision. This is how the patient looks, just for you to understand which shots are required to assess all the parameters. We need the full height shots. We need to understand what is with the knee joints, with the hip joints. And then we take the only correct decision, that is to remove axis and to try to help the patient without the axis, and she stands up and the parameters of sagittal balance are disordered, and then we perform another considerable surgery.
We perform a repetitive osteotomy in the lower backbone area. At the same time, we increase this lordosis, which is not quite physiological but optimum in this particular case. And only after that, the patient, after fourth operation, says, "Well, you can do a great job when you want to." So that's exactly what we've been doing in our practice. And just a few words about some other things, just to make reference to Dmitry Nikolaevich. It turns out not just Dmitry Nikolaevich, but also other specialists in the world think of whether we just perform a decompression without modifying parameters. Is a sagittal balance changes after compression, because spontaneously it increases, not goes back to the norm, but it improves. And sagittal balance disbalance can be seen in over 50% of patients with degenerative stenosis, but with the help of a standard decompression operation without instrumental fixation, we managed to restore this balance in 70% of the patients. Here is a study that shows information about lameectomy that can be confirmed by our case. In case of small deformations, we can only perform decompression. It removes symptoms, neurological symptoms in patients, partially restores some sagittal balance parameters, and improves the quality of their life. This is another example similar to the previous one. So in conclusion, I would like to say that aged patients, first and foremost, with the first and second deformation type, according to our deformation, European deformation, against restabilization processes. I would like to repeat that we are exposed to the same cycle. First, destabilizes. We have destabilized column, then it restabilizes. So if we perform fixed operations, it doesn't give any advantages, but instead increases the risk of post-operational complication and destabilization of connect segments. And modern macrosurgical and endoscopic technologies allows to adequately and a safe way perform decompression, preserving the same stability without very high recurrence. As for surgical technologies and the way they chose, we do it, where first we need to think not only, for example, the correction and how we need to correct sagittal parameters, but also other things as well. Thank you. Dmitry Nikolaevich is going to make a presentation about also sagittal balance, saying that we don't need it at all. So you can see the slide, and unfortunately the slide is in the English language, but we can see here the name, degenerative deformities. We can see that the title starts in the same way, like Sergei Gennadyevich presentation, but here in the second line you can see that difference, because I say screw sagittal balance or how to avoid a big surgery. In fact, when I was preparing for this session, and when actually I came up with this title, and when now I'm standing here, seems like these are two different persons, because after program was tailored, I read a book by Mr. Prudko about sagittal balance, but it was already a little bit too late. That is why I used a sagittal balance, but in a retrospective way. So I made a presentation, and after that I decided to add all the sagittal parts. So I have this kind of patient. Apparently, you can see that here we have a deformation. Is it generative? Is it a degenerative deformation? Yes, right. So here a patient had some very severe pains in the back, and also had a pain in the leg as well, on the back side. So these pains in the back and the leg varied depending on these activities, physical activity. And if I had read this book before, then I would have done it in a different way. I would have performed decompensation, installed cages, changed this lordosis situation, and then we would have started a discussion whether I covered enough number of levels. Sergei Gennadyevich would have analyzed that and said that no, probably you should have installed another screw here. Craig, what do you think? Do we need
fixation in this case, or it's okay?
For me, I would like to see X-rays of the entire spine. If I could see an X-ray of the whole spine, I feel like I could make a better decision. But since we have just this one picture to look at, I would say we need to somehow improve the lordosis in that section, which is quite abnormal.
Окей, понятно, да, что вроде бы рядом.
So it seems like yes, it would be nice to have a big picture. Probably we yes, like you said, the situation with lordosis is abnormal. Well, anyway, yes, it's not a full picture, but well, judging from this picture, we can see that here we decided to have 5 screws. But the point is that I don't know whether Mr. Shaginyan asked you about that or not, but we haven't considered a number of factors. So in order to make a decision, we need to consider a big number of factors, a lot of factors, and here we need to understand. So this patient came to us after a long period, and he had, this spinal column throughout his life. But at a certain point, he got those pains. He got some pains in the leg, and the neurological examination made us believe that there is a well-pronounced decompression of one of the nerve roots. So there was signs of compression of the nerve roots. And our task in this particular case is to localize the zone of root compression and to understand what particular nerve root is compressed and led to this situation. But it's not that easy. Just look at the column, and it has really changed. And we need to perceive it as a building, and we need to understand at what particular level there is a certain conflict a problem, because seems like all these storage level are pretty much affected, but we need to understand where the root cause is. So holds the information owns the world. We have to understand it, and that is why we start our investigation. We start to collect information. We start to study every foramina. Foramina, this is where the nerve root leaves the column channel, and we start at the left wing and the right wing of the building. And we see that the picture is a little bit different in the two sides. So let's look at level 3 and level 4, and we see apparently there is some hernia, and apparently vertebra are a little bit displaced, but as for the nerve root that we can see this hernia disc, and where hernia disc touches this nerve root, here we still have some reserve compartments, so it means that this nerve root has somewhere to move. Then the next level, number 4 and number 5, again we see that here we have some sticking out, but again look at the sagittal cross section. Here we can see some light compartments space. It means that the nerve root, despite the sticking out, has some space to move. And now look here on the left hand side, it seems like that this is the nicest level, but if you look at the foramina where the nerve root risks disc herniation, then we can see that this root is compressed and there are no reserved compartments there. So we identified that at the level between H-bone and level 5, so this level of the backbone, here we can see, I mean it is marked in the red arrow, it is surrounded by the so-called enemies, and it's kind of screaming out, asking for help. But this information is not sufficient. In fact, we like those principles of balance, and we understand that the spinal column has two basic functions, which is supporting functions, and we always need to understand whether the situation is stable or not, which segments are stable and not stable. We won't be able to do anything without that. And we also remember that the main function of the column is the protective one, because here we have spinal cord and nerve roots. That is why we first and foremost have to identify at what level and in what conditions our nerve tissues is kept. When I listen to different reports and presentations and all the strategies only based on some physical parameters, and I actually like them, really, starting from my school years, but at the same time we don't consider any other factors, it's not possible to come up with the right treatment method. So CT in this particular case gave us certain information that despite external ugly displacement of vertebra, and we can see the segments in this case are not moving, and seems like nature, and sometimes that our body, I mean, used some protective mechanism, some resources. Well, I mean, yes, maybe in quite an awkward way, but seems like our body tried to stabilize it a little bit. Yes, even though that's in an awkward way, but still we need just only to clarify, is it specifically L5? Yes, and that is why we use this selective blocking of nerve roots. So this practice become a very important tool for diagnosis. When we block the most suspicious level, you can see it here, we turn cut off or turn off this nerve root that we, based on CT results, we decided that it's the most compressed one, but we want to make sure again that we were right. And if after this blockade we see that our patient says yes, even at least for a number of hours or days, patient states, yes, now I feel a little bit better, then we understand that it was all about this nerve root. Then we proceed to a low invasive operations. Then we proceed to the decompression of this nerve root and get our results. Well, as a result, in the protocols, yes, we have information how to change the sagittal balance, how to do all this. So I think we need to have a neurological status fully analyzed, segment by segment. And if we see that there is a compression of one or two nerve roots, and if there is a deformation, but it is already stable, then in this case, a microsurgical approach should be used, and it can get us very good results, can give us. And now coming back to sagittal balance, to the book that I have read here, the patients that we have, we took a picture of the patient right after I read this book, we decided to take a full picture of this patient. So you can see that he cannot stay straight, and you can see all those sufferings even on his face. And we decided to check out all the parameters of sagittal balance. Anya has already mentioned that, but anyway, the first parameter, it is well demonstrated here. If we keep on our tables always all these parameters and formulas, we will be able to make this estimation. So you can see you need to measure this angle, then you go up to the middle of S1 line, then you need to draw another line that would be perpendicular to the femoral head, and we get this pelvic incidence. Pelvic incidence. And here we need to play on verticals. Here we have one vertical line and the same line that we had that went from femoral head to S1, which constitutes another angle. You can see during the previous measurement as well as in this measurement, in green we have the so-called normal parameters. But as for patients, we can see that they were marked in red because he did not fall within this admissible range. And another sacral slope, you know, it's like in a ski resort. We have different colors for different slopes, reds, green, blue, etc. And depending on whether the patient is in the green, red, or blue color, we understand whether patient feels bad or good. And we can see that the patient is in the red zone. It's very important when it comes to lordosis. And here we have information about this lumbolordosis. Lordose is can be straight lordose, no lordose, or maybe kyphosis. But here we have a very concrete parameters, and we can see these degrees marked in green. And if you go beyond those this green range, then it means that something is wrong and you are not within the green range, and it needs session treatment, especially this parameter. Here is my cervical vertebra, and this is hip point that we selected. And I get this vertical axis line, which is apparently abnormal, and you can see 143 millimeters, but the norm is less than 50 millimeters. Again, this is the patient that I refer to, and here we need to somehow fix it, starting from the H bone and higher. Here are all the parameters, and they are all red. They are within the red zone. And this is was taken after operations. So this is the picture after. So when we started to take measurements, probably somewhere not 100% correct, we saw that yes, we have different colors just for us to have a better perception, visual perception of the parameters. And here we can see that only one parameter previously was normal. Here is normal, even though that's so it's before and after.
So with the help of fixation correctly, yes, it was microsurgery, and the patient was operated on just 1 week ago. It's 3 days to be exact, 3 days only. And what I'm going to tell you, if we used only parameters of physics and mathematics, just measure the slope and back to the surgery, but we do not often have a hammer with us. This is kind of retro. Neurologists still buy these kind of hammers, but we do not need it. We check and yeah, okay, tomorrow surgery, I will come. Yeah. Just stitch me, I will go out. The patient is fixed totally, perfect sagittal balance, and somehow still he has problems in his leg. However, we have lots of assistance, amitriptyline, Genev, galperin, everything is all right. You know what I mean. And insurance companies and lawyers, well, perfect sagittal balance. The patient is mad, everything is okay, the surgery was good. Another example, a perfect patient to stabilize her, just a perfect one. We have not made a full-size X-ray. It was a little bit earlier. We just found her. She is in our Instagram, in our professional Instagram, and we took this picture from there. I said, we should check the parameters of sagittal balance with this picture, as this is the only parameters I could do for sure, because I don't see her slope, what is her pelvis slope, and this is what I can show, vertical axial line. What do you think? What happened to her? This is her. I don't know after how many days you saw our rehabilitation practice. This is 5th day. 5th day, this patient has recently had distortion of sagittal balance, complete distortion. Goodbye. And now, parameters of sagittal balance in nature. I think that if the same mechanism were used in nature, it's not always, well, it looks like the tree in the middle with the perfect sagittal balance looks like something hurts. That is why it cannot be fruitful. And, well, that is not, well, but the tree with the distorted sagittal balance feels well and is fruitful. That is why number one is quality life of the patients, and these parameters should be used to take decisions. And while taking this decision, we stabilize a lot. I have already told you, in our center, in Hospital 67 in Moscow, this is a historical fact. Andrei Anatolievich can confirm it, being chief surgeon. We had performed the first surgeries with the modern methods, metal constructions, transpendicular fixation, neck plate, all that. This is a historical first, for the first time in Moscow. But now we try to minimize our actions, analyzing neurological status, analyzing MRI data very thoroughly at every segment, and we have to study a lot CT data, and only after considering all this information we can take a decision. And after we make selective blockade of nerves roots at some suspicious levels, we take final decision. Thank you for your attention. Oh, well, that was a very good theme touched upon by Dmitry Nikolaevich, and truly we should distinguish between structural changes and we should not expand the indices for operation to stabilize the patient where it is not required. I totally agree with Dmitry Nikolaevich that if somehow, without knowing the theme, without knowing this theme and get mixed, we get disgusting results of the surgery. And of course, these functional poses which were demonstrated with these wonderful pictures, and for the second and third day total regression of pain syndrome can only demonstrate that Dmitry Nikolaevich carefully selected patients for decompression of nervous roots. And of course, the first thing to do, and first of all, we should treat patient, but not the X-ray picture. You can get confused between these two and misselect the tactics of surgery or treatment. And I'm very grateful for that. This is very important. Thank you. Any questions from the audience? Thank you very much for this discussion, for the knowledge that you share during many years. And could you please tell me, however, the role of sagittal balance distortion at recurrence of spinal disc hernia? Sometimes it happens once, and after 2 years the recurrence at the same level, and for the third time, to what extent the recurrence of spinal disc hernia can be reconsidered from the position of sagittal balance, and how often distortion of sagittal balance can be the reason for recurrence of spinal disc hernia? You know, for now, we do not have clear algorithms to predict identification of predictors of spinal disc hernia occurrence. Basically, the article about disc hernia, we tried to identify radiological parameters for retrospective assessment, and this data is shown in the Spine Journal magazine. And as far as I know, Nikolaevich uses these results, and it proves to be that parameters of sagittal balance are not at the first position. Mostly with the data that we got, there is a play of the height of the disc, degree of degeneration, type of the type, whether it's protruded or extruded, and lordosis degree. If there is inflammation to kyphosis, then principally higher possibility of hernia. Why recurrence of spinal disc hernia occurs? What is the difference between the patients of sagittal disbalance and hernia in the age? Because hernia of spinal disc presupposes young age. This is a very fruity disc, and there is something to fall out of it. And when the disc is out and where is the shift of the vertebra, there is a different problem, and this is something to do with the surgery. So we should differentiate between recurrence of pain syndrome and recurrence of hernia, because this is just the reason. It is substrate of pain syndrome and the recurrence of pain syndrome, and we can often see that in publications is mostly related to other reasons, disability or stenosis or deformation, which occurs within the life cycle. And as long as patient had primary surgery, the more probability is that the surgery will be required again. But that doesn't mean, however, that we don't need to make surgery on these patients, but we hope that before the next operation the patient will live a good, comfortable life, and we shouldn't be afraid of a recurrence of hernia. And if we operate on again, then the probability of good result is still high. Thank you. I'm I'm sorry, I was late and unfortunately I couldn't listen to your lecture, but I have such a question. If hernia is not there, but a person is bending, is it possible to use physical exercises to prevent further moving on to can physical exercises avoid this situation, this stoop? Well, it never helped me. I'm trying to do exercise, but it never helped. Well, the main thing is some stooping people feel better than those who walk directly, but the main thing is quality of life. Another question? Good afternoon. My name is Larisa Kazitsina, pediatrician, and I have a question like this. How do you treat alternative method of treatment that is a multi-profile Bubnovsky machine? Multi-profile Bubnovsky machine. Non-surgery treatment of a spinal disc hernia. I'm sorry, can I tell you the following thing? Every lock has its key. We cannot open all the locks with the same key. That is why I understand this is not alternative. When people they say hernia alternative, no. Medicine can agree that this is an art. See, we are having the floor, and maybe we actually treat all the patients in a different way. This is an art, but it doesn't mean, okay, he is only doing surgery and he is only doing something else. It's no alternative. Every patient requires specific treatment. We said that we have 20 patients in our department. Let's take medical histories. For instance, hernia of disc 4 or 5, and all of them will have different treatment. All of them will have different results. Number one, patient 18 years old. The second one is 78 years old. You understand the treatment is totally different. One of the girls would have this acute period when she comes stooped, she's crying, paining, and after 1 hour she's happy and going to kiss you, and because her pain was gone. And it took half a year for a person to suffer that. And another person had a hernia and never regressed after the surgery, and with some paralysis it's gone. One person weighs 40 kilograms, another one 150 kilograms. Genetics is different. See, they show us girls when she bends, her head is between the knees, and the others cannot reach the floor with his hands. So people are different. Way of life influences the situation. It's important whether a person is lonely or lives in the family. A person who works in the team and a person who stays at home, who is unemployed. It also influences. So lots of factors. People are so different. That is why when it looks like we need to make a surgery, and one person will still walk without a surgery, and the other one no. In Japan, they do not operate people who doesn't have money. Not because the surgeon will not earn money, but because after the surgery they need specific things which the person should visit gym, should have massage, should have time, should have an opportunity. If he doesn't have these opportunities, this surgery will be useless, you know. And this is kind of art. There are no standards, and you know, we do not treat with the X-ray pictures. It's the same like taking a picture of a car to the master in garage and ask, what is this? This is art. And even if we treat all together or separately, we'll do it good. But the main thing is that the first step made by him, the second by me, and the third by something else. But to answer your question precisely, I treat it as just sports, as physical culture. Sports is useful, no limitations in this respect, but I don't think that this is a treatment procedure. Any additions to Andrei Anatolyevich? Just a few words. You know, the highest number of addresses of people because of back pains in Holland, in the Netherlands, and it correlates with the highest number of people who live with the payment from the state, and the lowest from Chinese peasants who collect rice, and they work in cold water, and they almost never aggress. So all that influences. Rice influences, or what does it actually influence? You see, now everybody is quite lively, and thank you for this urgent question. Well, I cannot keep silent as well. Well, I should say maybe it's not a very popular thing for the audience, but generally the presence of disc hernia is a normal condition. It means that step by step we are getting older. Of course, we do not agree. We want to be eternally young, but unfortunately, we don't know how to be eternally young. That is why hernias were, hernias exist, and hernias will be all the time. But the question is, when, as Dmitry Nikolaevich said, when the quality of life is dramatically decreasing, and here we have different situations. They can be partially orthopedic, and this is our part will win. Our part of this session will win. But possible there are conflicts told by Dmitry Nikolaevich, and it's enough only to make decompression, minimal interference, and everything will be perfect. And the presence of recurrence of disc hernia is such a multi-factor thing, and it also depends on what kind of surgery techniques were used during the first surgery. It influences as well. Sometimes a surgeon can just say, this is a historical fact. The disc hernia were formed repeatedly, and only the surgeon know how well it went during the operation, how it is planned, whether it was according to the plan. So recurrence is multi-factor thing, and there are no randomized researches which would identify one specific indices that then would result that everybody would treat patients so that there would not be recurrence. Thank you. Well, let's continue the session, otherwise we will lose the time. Greg Anderson, our friend from the USA, will speak about innovative methods of decompression, non-indirect decompression treatment.
Thank you. I'm really enjoying this lively discussion. We'll change the topic just a little bit now and talk about something new that most may not have seen before. This is back to the topic of spinal stenosis and a new technique. So the problem of spinal stenosis is extremely common and very much related to aging. We know that as many as 65 million people in the world have this condition, and as our various populations get older, the incidence of this is increasing. And we see a pretty good picture here of a normal spine and a stenotic spine with less space for the nerves. And we feel like we have a pretty good understanding of this condition because this is unlike disc herniations, which have a strong chemical basis. This particular condition is very much based in a physical problem, or the problem of pressure, and this has been shown in many studies, but some of the interesting work comes from Japan, where they have placed small little sensors and they have patients with stenosis perform various activities. For instance, when people with stenosis stand and walk, they tend to have more pain, and they can correlate this with elevated pressure around their nerve tissue. When they are leaning forward or sitting, often their pain is reduced. So a new strategy for this is the idea of elongating the pedicles, and I'll show how this might be done. But this would be a minimally invasive technique done through a percutaneous approach to expand the spinal canal and make more room for the nerve tissue. When we lengthen the pedicles, we can see the following. This graph shows the pressure in the nerve tissue measured in the lateral portion of the foramen or the central canal, and we see how as we lengthen the pedicles, we see a pretty dramatic drop in pressure, particularly at about the 2 millimeter mark. So just a small increase in the length of the pedicles and quite a substantial decrease in the pressure on the nerve tissue. And if we look at what happens in the surgery, we see the space for the spinal canal increases. We have the original area of the spinal canal, and after elongation we have this new area, and we know that can decrease the pressure. And so if we were to place this therapy in the spectrum of treatments, and we compared it, say, to a laminectomy, which is a more traditional treatment, with a pedicle lengthening osteotomy, because we are not removing any of the normal tissues, we don't have the potential to destabilize the spine, which can cause a certain set of problems. And unlike some of the therapies where people place spacers in between the spinous process and we're blocking movement, we see that our motion is more anatomic. It's more like a normal situation. So we think this is theoretically beneficial. So how do we do the procedure? It's done in 3 simple steps. These are all done through an image-guided technique. In step 1, we must make a hole in the pedicle. In step 2, we will cut the bone from inside the pedicle to out using a special instrument. And in step 3, we're going to put in a special type of screw that elongates, and by elongating will increase the spinal canal dimensions. So I referenced the special saw, and this is how this instrument works. This is a handheld instrument that has a small flexible blade that comes out of the side of the instrument, and the surgeon can control the distance that the blade extends or retracts by turning a knob. And by doing this, this can be done in a very, very controlled fashion. When we manipulate the blade length, we manipulate it in 1/8 of a millimeter increments, so very small increments, and in this way we can do this safely. As for the implant that's used, it looks like this. It is a screw that has 2 parts, an upper and lower part, and by turning a middle section, we can make the screw longer, and this will increase the gap of the osteotomy. So, is there any literature? And I must give credit to my colleague, Dr. Sergey Milavik from Nizhny Novgorod, because he's published results on using this in a population of patients for a minimum 5-year outcome. And in our field, 5-year outcome is quite impressive. Only a few studies have outcome of this long or longer. And essentially what his data shows is that the scores that we use to quantify the patient's symptoms improved very significantly, both statistically and clinically significantly, as you can see from the graph. And they're maintained out to 5 years. And this is a little unique because we know from other literature on stenosis that there are various techniques that work well. For instance, taking laminectomy is perhaps the gold standard. Laminectomy works very well for spinal stenosis, but if we follow the patients over time, we start to see that their results over time reduce. And so we think this is hopeful that things can be maintained. In addition, it's very important to think about the safety of the technique, and so from the studies that have been published so far, we haven't seen problems with a dural tear, we haven't seen nerve root problems, we haven't seen infections or bleeding because it's done through a very small incision so far, and the healing has been very favorable because after the bone is lengthened to the new length, the bone can heal, and this will reestablish the spinal canal in the new position. The data also shows that the area of the spinal canal by using this technique is increased by about 115%. So, a little bit over double the area after doing the lengthening. So now I'll go through just a quick case to show some pictures, and I'll move a little quicker in the interest of time. This is a patient that has stenosis and grade 1 spondylolisthesis. In the United States, I think most surgeons would probably do some type of decompression and fusion for this type of case. And we see here the MRI. We do some surgical planning before the surgery. We want to measure the size of the pedicles because we need to know what size implant will be appropriate, and also the angle it will help us with our cutting procedures. The cases have been done so far mostly using fluoroscopy, either in a single plane or biplanar fluoroscopy. We mark out the location for the incisions, and we like to use this view. This is called an en face view, which is sort of an angled view right down the axis of the pedicle. We find that to be very accurate. We make a small incision about 12 millimeters in size, directly in line with the pedicle, and then we use a special instrument that will open up the pedicle passage. We're going to ream a hole into the pedicle. We want to make sure that this instrument is docked in the center portion. So you can see on this en face view, we want to be right in the middle of the pedicle within about 2 millimeters to make sure that we're going to be accurate. And here we are with the reamer in place. We have on the instrument some ways that we can tell when it's at the proper depth. And then we're going to use the saw that I showed to cut the pedicle not completely in a circle, because we know the size of the pedicle is not round exactly, but we're going to cut in zones or quadrants so that we can do this accurately. And this shows the saw blade during the cutting maneuver. You can see on a side view and a front view where the blade is positioned, so you can follow this along. We must remember the location of the nerve tissue, especially along the medial and inferior pedicle, which is where things are most vulnerable, so we're going to be especially careful. And then we place the implant and lengthen the implant, and in this particular procedure we did it above and below the level that had the slippage. So after surgery, we expect the patient's leg pain to get better, and that's what we see in the majority of cases. We mobilize people immediately, tell them they should walk at least 30 minutes a day, and they limit their bending for 6 weeks. Most of these patients can be done with early discharge. And we see very good healing of the bone. So these are patients that are 6 months out, and now the bone has been reestablished. So their spine now is going to be permanently enlarged. So the advantages are good safety, good effectiveness as shown by the 5-year data, early recovery, and we hope long-term benefit to patients with this condition. For the future, we think this procedure could be something that could be applied robotically, because all of the steps in the procedure are very much steps that modern robots would be capable of performing. So we're hopeful that a technique can be advanced further in this way. Thank you for your attention.
Вопросы? Есть вопросы?
Do you have any questions? Thank you very much for your presentation. I have 2 questions, if you don't mind. The first question, so can you apply this methods during terminal stenosis, where we have compression of roots, nerve roots, and it goes at a certain positions a little bit lower? And does it have any specific features when it comes to patients with osteoporosis, when we can see with a degenerative stenosis of the spinal column?
Thank you. Those are excellent questions. As to the first, it does work for foraminal stenosis in so much as the foramen is enlarged by the procedure, but I think you have to be a little careful. I would not recommend using the procedure if there's a disc herniation, because I think the presence of that could still cause some chemical irritation of the nerve, and the patient may not suffer relief. So I think it's more for somebody that has more of a bony disease, these chronic degenerative processes with narrowing. The second area that I think we have to be careful is if there's severe collapse of the disc space, where the nerve root is being impinged by the supraarticular process, then I think it would not be ideal there either. As to your second question, osteoporosis at the current time we believe is a contraindication. And when we define osteoporosis, we're talking about T-score greater than minus 2.5. In this category, we would exclude those patients because the concern would be that our implant may not have sufficient strength to open the gap. In that we've excluded those patients so far, we've seen that it works well. So people that have less severe degrees of osteoporosis, it seems to be effective. But an important point is that when we size the implant, we want to get the screw to purchase the inner cortex of the pedicle. So unlike our normal fixation, where we may not pay attention to the screw being, sized to the inner cortex, in this procedure it's quite important because only then can you ensure that you have enough fixation to do the movement of the spine.
Спасибо.
Большое за интересную презентацию. Очень элегантная методика решения проблемы стеноза. Но не сталкивались ли вы в этой выборке пациентов, применяя эту методику, с тем, что мы, применяя этот метод, 100% меняем взаимоотношения смежных фасет суставов, смежных уровней, выше и ниже лежащие? Мы, по сути, не намного, но делаем дислокацию в суставах. Поэтому вопрос такой: сталкивались ли вы с решением, конечно же, вопроса стеноза клинически, и радиологически? Не было ли появления боли, связанной с фасет суставами? И логично, если была, то какими методами? Может быть, дорецепция прогнозируема, либо чуть позже?
Yes, thank you. That's when you lengthen the pedicle, you place extra compression across the facet joint. And so early on there was a concern that the added pressure on the facet joint could be the source of some new back pain. So before any patients were done, there was a finite element analysis study that was done along with a cadaver study to look at how much pressure does the facet joint experience during the lengthening. And what was found is that, when you extend your spine, you increase the pressure on your facet joint. And the magnitude of the increase is roughly about 30%. There's other studies that show this. So when you do the pedicle lengthening, you have about the same amount of increased pressure as you do when you extend your spine. So it's within the physiologic range. So we felt this was likely to be acceptable, but in the first patients that were done, we looked very carefully at back pain, because if we're helping the patients in their leg, but we're creating a problem in their back, we may not have done any favors to the patient. What we found is that the leg pain, which on average on a visual analog scale was about 7.2, that decreased to about 1.9. And the back pain, which was not as bad, was in about a 5 on the visual analog scale, decreased to about a 3. So a slight improvement, but fortunately no worsening. I think the other part of your question is, could you create some type of instability, right? If you're changing the dynamics of the spine, maybe the adjacent level has some type of instability. And that has not been seen so far. An important point is that when we lengthen the pedicle, initially one might think that the dorsal column is being pushed backwards, but the dorsal column is much stiffer than the ventral column, so most of the movement of the vertebra is ventrally. So you will see, if you watch on fluoroscopy while you're doing the lengthening, you'll see a slight movement in the vertebral body, very minimal movement in the dorsal column, a slight increase in lordosis, and it seems to be well tolerated, probably because the gap we're making is very small.
Спасибо за дополнение. Спасибо.
Thank you very much. Good afternoon, dear colleagues. I'm from Krasnodar, and Greg Anderson, could you please say when a vertebral body displaced, and if it is displaced, what about sagittal balance? Does it also impact the sagittal balance?
Very good question, thank you. So as to sagittal balance, this issue has not been carefully characterized so far. There was a researcher in Italy that looked at this in a small cohort of patients. He's actually doing a PhD, and his thesis is exactly in this topic. And I've had a chance to counsel with him regarding his preliminary data. And the preliminary data looks favorable, but the biggest problem we have is the patient number is quite small. So I think, and he's doing full-length spinal films and really measuring all the parameters as we've learned today. So I would say, I think it looks favorable, but I'm really waiting for his report because I think it will be an important answer to this question.
Спасибо, мы вынуждены продолжать, у нас осталось 10 минут до...
Unfortunately, we have to continue because we have only 10 minutes left. Alexander Yuryevich Mushkin, our colleague from St. Petersburg and head of Department for Infectious Diseases of Vertebral Column, told us about another important issue when we talk about such delicate things and about very interesting things. I would like to say that it's very difficult to go back to something that I want to discuss. I really liked the presentation by Alexander Vladimirovich when he showed that red flag. So I'm gonna talk about the situation is that when we have a situation when you are not in the red zone, but also when you are black zone, if you use that ski resort terminology. Because do you remember Alexander Vladimirovich said that situation when you have already overcome the level of the red flag, there is no way home, no way back home. But you are in a situation where we also have an infectious process, and this is a process that as of today is quite a little bit at the very edge. And because I've had, it's true that I am here to represent a department who is responsible for treating different infection diseases of spinal column, and you should say that we actually perform up to 800% or 800 operations of this kind in the country, and we perform half of these operations. And also, these infection diseases can be caused by some side effects or complications, and I would like to share what kind of actions we take both with our adult and patients and little patients, kids. To me, it would be more interesting to understand why we actually take this or that, those solutions during infection, affection of the column. So when we talk about the degenerative affection, this is a patient who was operated 2 months ago in our hospital, and he suffered from a problem with the column for 6 years, and apparently we have here a very complicated inversion of the column. The whole column almost had been destructed, but it manifested almost no symptoms, and that is why we got him and saw him in our hospital only 2 months ago. Yes, he felt some pain prior to that, and here are the questions that I found interesting for me from the point of view of infection vertebrology. So in fact, this infectious vertebra is reflected very much in foreign and Russian literature. So approximately from 10 to 20% of all the infections sections dedicated to this kind of infections. I mean, infections and complications in spinal surgery and vertebral pathologies. As for global publication trends, they were reflected a year ago in a very nice journal, Global Spine journal, and I wanted to know how many actually works were dedicated to this or that subject. So infectious diseases and problems. Here we can see, for example, the one spondylitis and spinal tuberculosis, spinal epidural abscess was also one of popular subject that was covered by such kind of articles. Spinal epidural abscess, 3 publications.
Neck, chest, and lower back, 4 publications. And if we consider what kind of trends in Russian and foreign literature, well, they're totally different. These ovals mean a general number of or share of publications dedicated to each of the parts. Russian publications and not only Russian. In brackets, I specified BRICS countries, which are quite close to us as to economical and mental level. First of all, the issues of spondylitis, less the issues of epidural abscesses, and lowest work. We do not like to speak about infectious in surgery interference. Well, foreign books of the countries of Big 7, Big 8, Big 20 doesn't matter, but infectious, primary infectious minimal articles, epidural abscesses, pure neurosurgery. Another thing is that now most of them are treated conservatively. Most of the epidural abscesses are treated conservatively, and a huge pool of works dedicated to infectious is a result of surgery. Speaking about surgery, first of all, we should agree about terminology, and I believe here it is very simple, because spondylititis, the name of the pathology does not mean anything. Until 1996, the classification of Calderon-Larsen identified spinal zones and actually attributed to them some special spinal infections. That is why spondylitis and spondylotisitis is only specification of the zone within the inflammation process. Call it osteomyelitis of spine, because you will make a mistake, because actually that is what it means. Spondylitis, all these are spondylitis. They are totally different diseases. Tuberculosis, non-specific osteomyelitis, and other diseases. Non-bacterial osteomyelitis, the only one which is not related to infectious, but this is also spondylitis. This is also autoimmune problems, and this classification, in my opinion, is quite convenient from the point of view of perception. When we take some tactical decisions, we should understand what we used as a basis. Either we mean etiology, and then you see the scheme of etiology classification, or in the red color, you see what is of principal importance today. These are complications after surgery. I'll specify those in detail later. Or we use pathogenesis, and then we deal with primary inflammation process, secondary inflammation process, its complications of different nature. But we live in a real time, and for 10 or 15 years, we say that unfortunately in our country, which is among the countries where we see considerable number of patients with a pathology such as immunodeficit. We speak about secondary immunodeficit, about AIDS, but let's not forget about primary immunodeficits and the infectious problems at the background of primary immunodeficits are also various. Complications, everything is very well structured because these complications are divided into classes: infectious, neurosurgical or neurological, orthopedic, and social. With each of these complications, those who start dealing with infectious problems of spinal column should classify it like inflammatory abscesses, destruction, that is unquestionable and it recovers this or that surgery. I have left outside the brackets that when we speak about infectious problems, we mean that any infectious process can be cured by target pills, antibacterial medical drugs. That always prevails when we have an idea of infection. Neurological, today, it's not enough to say that a patient has this or that neurological complications. They should be described. An anatomical substrate should be found, which should be located inside the spinal channel or inside the bone marrow. And it's important to understand that sometimes even cured beautiful process, beautiful result of the surgery will not result in improvement of neurological condition of the patient because he already had intramural changes. And pure orthopedics, deformation, instability, support distortion, the terms that are clear to any orthopedics. And dealing with this infection, we reached the notion of how distortion of balance can happen with the patient who had problem with the spinal column, because optimal result of infectious process is blocking, and blocking is final stage of degeneration. Treatment, everything is quite simple. On the fourth number of surgery of spinal column, we dedicated the whole section to that, to publish the project which is called National Recommendation on Infectious Processes. This is not the first document. 4 years ago, a group of neurosurgeons prepared clinical recommendations, but they were prepared with the aspect of neurosurgery. And I believe that as to infectious, this division into neurosurgery and orthopedics is more than conventional. Conservative therapy, I have already mentioned, and as to surgery, and I would like to attract your attention to the point that I have noticed by chance, but I could take a picture in a conference in Toronto. There were clear indications for surgery treatment of infectious diseases. That is compression of neurostructures, that is instability, deformation presence, inefficient conservative treatment, but pay attention to the last 2 points below. Soft indications, not relative, but soft indications to operate to surgery. Drug multi-resistant bacteria, which reduce efficiency of conservative treatment, and the last, too expensive conservative treatment. It will take many years to treat a patient. It will be too expensive in comparison to surgery, considering that there is also risk of surgery. And the question of technical classification, during technical classification, they are solved very precisely. A publication of 2017, Italian authors, new classification of spondylodiscitis, acute processes, non-chronic processes, and I'm very pleased that this year in Russian literature, in the magazine Traumatology and Orthopedics of Russia, we already have a comparison of different technical classification with the applications of most popular things in the world. Classification of key forces, which are normally complications of infectious processes, work of Indian authors. Today, it is very convenient to use this, even it is not used everywhere, because there are different kinds of kyphatic deformation of spinal column, which requires different options of osteopeny of spinal column. This is very hard surgery, but it is done and it's absolutely available today. And what we cannot but mention when we speak about surgery of spinal column, about the area of surgery. Today we have some standards. There is a time classification of this time: early, delayed, late. And as to early and delayed, there there are at least technical decisions which are clear. If this is early stage, then this is a revision. If there is a removal of pathological tissues, the constructions should remain. If it's late, then a revision and deconstruction of pathological tissues and unstable construction. Well, I'm sorry, it's mistake. At early, it should be kept, and at the late, it should be removed. And the question is, when we speak about delayed infection, and these individual decisions are always a very slippery area, because these are decisions that doctors should take together with the patient, whether to remove unstabilized construction. Another question discussed for the last couple of years is how we treat low pathogenic infection in surgery of a backbone. And it has already been mentioned. We mentioned that in Samarts, who is almost directly related to that. And the question, which in my opinion is the most important, it's absolutely a non-surgery question. This is arrangement issue, where patients with infectious problems of spinal column should be treated. What kind of a help and at which stages that can be provided? Diagnosis, and diagnosis is not only X-ray diagnosis, but also confirmation of the fact that this is an infectious process, and also a treatment. And well, I have made this scheme, and actually this is direct analogy with trauma centers of different levels, maybe in diverted order. And if we use the schemes that I have already shown you, if we bring classification to this system, we can single out where acute processes patients should be treated, patients with chronic processes. And the question is where these patients should be treated is not limited to the question itself, because the hardest question that we have, and I believe not only for me but for others, how much this treatment costs. This is the data which were shown in Toronto. Average cost of treatment of a patient with primary infectious is $24,000, and the cost of treatment for patient with infectious in surgical area grows multiply, reaching $400,000. Those who work in our country and know what is the system of national insurance, they know these prices. And I do envy medicine in Moscow, which managed to undertake into a program providing the money for the infectious diseases. Here we have 900,000, and actually it is 988,000 per one patient in Moscow. And here is a question: which medicine are in, patient-oriented or financially organizational? Because the true cost of treatment of these patients is not covered by the finances which are allocated for them. Thank you very much. Well, actually we are pressed for time, but can we ask some questions? Any questions to Alexander Yurievich?
Really interesting presentation. I always have trouble knowing, I want to present a case to you and understand I want to present a situation and understand your preferred approach. So we sometimes see people that have a fungal infection like coccidiomycosis, which is systemic, and they have lesions in different organ systems, maybe in the spine as part of the problem. And the antifungal therapies may be effective at stopping the spread to some degree, but they don't seem to be effective at curative treatment. So the question I have is, how thoroughly should I debride the spine when I go to treat this case? Is it something I need to be radical, or is it something I can leave some tissue that's questionable, and if I get a stable healing of a fusion, is that acceptable?
Well, Well, I understand, and actually it was related, I understand the question. This is the hardest patients. Moreover, today fungus infections are considered to be as a marker of immune deficit conditions, not only infectious immune deficit conditions, but also immune deficit conditions which resulted by chemotherapy, and before people just couldn't live to this condition. We have fungus infection of patients who are with chronic hormone therapy, cytostatic therapy. These are the patients with oncological diseases and also patients with transplantations. Principles of dealing with these patients, of course, first and foremost, there is chemotherapy, but for the situations when this condition is complicated with number one, neurological disorders, that is distortion of spinal column with the deformations and with the pressure over the spine, and the patient I have shown it with the patient with a heart disease with hardest phlegmonas, which are not limited. It is a peculiar file which is called aspergillus when abscess does not create capsule, so it just eats out all the soft tissues, thus distributing it totally over the whole organism. And in this situation, sanation of the center itself, a radical sanation is not possible. I totally agree, especially when we speak about generalized mycotic infections. And at least this mechanical removal of pathological substrate would improve condition of patients and increase efficiency of conservative treatment, which is always first and foremost. No other questions? If we have no other questions, then the section is over. You know, the next session will take in 10 minutes about arrangement of healthcare and private clinics experience and how it is done in Moscow, for you to understand what kind of system is that. Many people do not know that you can actually have free surgery on your spine for any citizen of Russia with implants or without. We do not know some things, and we will show some interesting cases which will surprise even professionals. I'm sorry for this. And it will be interesting to know for the surgery of spine in the USA, private clinic, university hospital, how it is arranged, federal centers of Russia or private clinics, well, how to get treated in this or that clinics, and in Moscow, about Moscow, Andrei Anatolyevich will tell, and what I also want to tell you, for you to understand, well, how I won in competitions in sagittal balance only due to learning these books, studying these books. And that is why everyone who supported me in this competition should read this book, because why I like this book, it is very well illustrated, starting from the cover. And further on, all these parameters which we discussed, actually this is really very important for our patients. And I have an announcement that next session Alexander Vladimirovich Kruchko will give to the most active participants who asked a lot of questions and so on and so forth. He will give prizes. These two small books, the first one, positions 1, 2, and 3, he will distribute it during the second session, the next session. And at the next session, you can ask at the next session. Could you please tell, if a person has scoliosis of the second degree, but the person is quite young, what kind of recommendations as to orthopedics lay in order not to make the process worse? Well, just to prevent, what kind of orthopedic soles we need to prevent scoliosis development further on? I think Sergei Gennadievich will answer. Well, I'll try to answer. Can you hear me? I need to specify whether we're speaking about a young person, and if we are going to treat a person with a scoliosis, a growing body, with a second degree of scoliosis, it's preferable that orthopedician would check them from head to toe and also assess possibility of flat feet. And if it's not there, then naturally in idiopathic scoliosis of the second degree, the soles will not mean anything. Moreover, scoliosis, idiopathic scoliosis, as it is called, idiopathic means of unknown nature. So precisely we know its nature. It's in our gene mechanism. It is closed there, deciphered there, and as you understand, with the help of orthopedic devices, you cannot influence genetic material. It's not possible. That is why these kind of patients we carefully examine. We try to improve their muscles. We try to stop development of scoliosis, but unfortunately nature can win all the time, and sometimes we have to make a surgery. Cannot hear without the mic. We should develop the condition. He should support himself. In 20 minutes in a Modrov hall, in the same room.